Thank you very much, Dr. Sardari, for this impressive presentation. I think this shows that being together with our cardiology colleagues, we can advance therapy options together with the structural heart disease options and the transcatheter options. So just one question from me, and then I'll pass on to my colleagues and moderators. I have seen that you are obviously, I'm likewise a lover of partial rings. Could you elaborate a little bit more on your choices of rings? And the second question is, which is a very hot topic in the TEER approach too. What is your belief of secondary mitral valve disease? Do you think there is any space, given the fact that we can approach this now endoscopically, so we might be offering our patients something slightly better than the older surgical results that we had in this type of patients?
Yeah, thank you for the kind invitation again, and for your questions. For the first question with regard to the ring, I'm using nowadays predominantly bands. And the reason for that is, as you know, there is no annulus at the level of aortomitral quarter. That is a dynamic place of the annulus. And the whole annuloplasty concept ring works because you pellicate the annulus from the trigonum to trigonum. So what is important is that you have something in place from trigonum to trigonum. So that's why in most cases, I think a band is more physiological and much better. Obviously, in functional mitral regurgitation or mixed disease, so if you have, for example, a P2 prolapse, but you have an extreme annulus dilatation because this is a far more advanced disease in volume overload, in those cases, you can opt for a complete ring. But the concept of the ring only works because you have two fixed point trigonum and go from trigonum to trigonum. But what is very important, the very correct use of the band, because the thing is, in the ring, you cannot make a mistake, but putting a band, you could make easily mistake if you're not an expert, because you need to have the trigonum very fixed to the band. With regard to your second question, I think the treatment of the mitral valve disease in functional mitral regurgitation is palliation, because it is not a disease of the valve, but a disease of the ventricle. So as a surgeon, I'm very reluctant to treat surgically functional mitral regurgitation. There are only two instances that I'm open to do that. One is if you have atrial mitral regurgitation, which is because of the atrial fibrillation. And in those patients, you have in those patients also not only mitral regurgitation, most of those patients have also tricuspid regurgitation and AF. So during the operation, you treat the underlying cause, which is AF, ablation, and then you put two rings to treat the consequences of the underlying cause. That is one. And the second is, obviously, if you need to revascularize the ventricle and you have still viable lateral wall, you can revascularize. So you treat the underlying cause of functional mitral regurgitation, in this case, restriction of the P3 area, and you can repair the valve. Otherwise, in those cases, if there is already an infarction, you need to replace the valve because the results are not well. Or if you don't need to do any revascularization and you have a purely functional mitral regurgitation without atrial component, I would opt for TEER, because I think in the end what you do is palliation, and you shouldn't do a major surgery for that.
Thank you very much, Dr. Sardari. To pass on some remarks and questions to my colleagues and my moderators, Dr. Katsianos would like to contribute to this conversation, and then Dr. Papadopoulos.
Thank you, Dr. Perez. I have a question for Professor Castle. So we have cautiously selected our patient according to the criteria presented by Dr. P. Barreau, and we have a very good imaging, pre-tier imaging according to the information presented by Dr. Chrysocheris. I would like to ask you, in terms of device choice, when would you choose a MITERA clip, and when would you choose a Pascal, in the knowledge of the differences of the characteristics of the two devices? Thank you.
Yeah, that's, I cannot answer this question really for everybody, because it depends on the experience of the user. The one has more experience with the one device, the other with the other device. In my opinion, the pro for Pascal device is that you don't give too much tension on the leaflets. What means when you have to foreshorten the annulus, like in a functional mitral valve problem, then I prefer more this nitinol device. In my opinion, on the opposite side, in degenerative disease, I think it is good to have more clip sizes. And in this, I like, for example, then also using the smaller clips. In these cases, I prefer more or less the MITERA clip device. But I think more or less the Pascal users, they use mainly the Pascal ACE, and the MITERA clip users now, they use mainly the W clips, and I think it's more or less the same treatment option with both devices.
Thank you very much.
Thank you very much, Dr. Castle. We're really impressed by your work too. Dr. Papadopoulos would like to make a comment or maybe ask a question.
I would like to make a short comment following Professor Sardari lecture. And I would like to say that according to guidelines, we have an indication of 2A for transcatheter edge-to-edge repair in functional mitral regurgitation patients, but only for patients that are not suitable for surgery or are at high risk. Maybe I agree with atrial functional MR that should be treated surgically, but maybe these indications should change in the following guidelines, because in routine practice, when we screen a patient with secondary MR due to LV remodeling, we usually go with the transcatheter option and not, we do not send these patients to the surgeon. I would like a comment on that. And my question for Professor Bibaro is, in real world, which patient will you reject from mitral TEER? Considering that even though we might not change the prognosis of the patient, we certainly reduce the hospitalizations. And this is something that we experienced from our team with Dr. Sparias, from all patients that came, even with very low ejection fraction or advanced heart failure. And if you use advanced strain techniques for remodeling of the LV at follow-up. Thank you.
Yeah, so that's a very good point. I think there are two ends of the spectrum that may be where MTR should not be considered as the first options. I think on one hand, there are the patients where I always felt that if you think, in terms of lifetime management, and the patient is eligible for a surgery, a surgical mitral valve repair, especially for primary MR, Secondary more we can discuss, but I think it should be, we should do a surgery first, because if you do MTR, you may compromise your future repair. It might be difficult to do repair, and finally it's going to be a replacement. But that's, I would say, the easy end of the spectrum. The other end of the spectrum, what we were calling, in the early days of TAVI, the cohort C, were the patients where maybe the heart failure is too advanced to, and probably the TR will be futile, because it's a procedure that has a cost in terms of paying the device, the healthcare resources, and if it's futile for the patient, then it's a waste of time and money and resources, and taking a risk for the patient. So I think, as I mentioned, the patients that have very dilated LVs, LV and systolic diameter more than 70 millimeter, that has been, by the way, used as a exclusion criteria in COA. If you have a very low LVEF, or if you have this very large LV and they're studying for more than 140 ml per meter square, they might not be the best candidates. And at least you should try to optimize first really the heart failure therapy as much as you can, the pharmacotherapy, and including restructurization if needed, before eventually considering TR. I do not mean that we should not consider TR, but because sometimes in some patients, at least to improve quality of life and prevent rehospitalization, that might still be a good option, even if you don't maybe have any impact on the improvement on the longevity of life. So I think these are really the patients that may be used. And maybe we need, I'm still, a bit, I mean, these criteria that I provided are relatively simple, and this is what you may have in guidelines, but maybe we need more advanced imaging to really identify the patients who actually may respond to TR versus those where the treatment may be futile and should be treated conservatively. And I think, the myocardial strain may be useful. I think also MRI, T1 mapping, if you have a ventricle that is highly fibrotic, maybe whatever you do, it's not going to remodel and it's not going to respond. And then the indication of TR would be only for improving quality of life.
Professor Pibarot, mille merci. That was really nice. And it shows that this collaboration helps a lot, because we need to identify which patient is for which treatment.
Can I answer the question? Don't know whether...
Yes, please.
There was a question with regard to the atrial mitral regurgitation. Actually, there is no evidence what is the best surgery or... so I was answering which kind of patients I would accept as a surgeon if you consider the functional mitral regurgitation. With regard to the guidelines, it's very important to state that the treatment choice of the functional mitral regurgitation is guideline-directed medical therapy. So it is a 2B actually in Europe and 2A in US. So if that doesn't work and patient is still symptomatic, then you can opt for TIA. So,
right.
and you do it for the palliation. So that's
maybe Dr. Patakos would like to make a contribution. As we started 10 minutes late, would like to deliver the table.
Perfect.
On time.
So we have Dr. Reardon in the audience with us, who just wanted to make a quick final thought, and then I think after this we could continue this conversation for 3 or 4 hours, but we do a disservice to the next session. Thank you everybody for being with us. I'll let Dr. Reardon give us his input, and then Dr. Pereas, I'll ask you to close the session. Thank you everyone.